everyone, hello and welcome to aidsmapLIVE, NAM's panel discussion on HIV and mental health. My name's Susan Cole and I'm here with a tremendous panel who I'm going to introduce to you now. First of all, we have Dr. Rageshri Dhairywan, who's a consultant physician and researcher in HIV medicine at Bart's NHS Trust. She has a particular interest in race, gender and health inequalities. Next, Dr. Tristan Barber, wearing almost the identical thing. Is this like the doctor uniform? He's a consultant physician in HIV medicine at the Royal Free Hospital with a research background in HIV-related neurocognitive impairment. Tristan did send me this morning the longest, most impressive bio I have ever seen in my life, with every acronym under the sun, it seemed, included. But I would like to give a shout out to the British HIV Association, who were mentioned there, so thank you. Next, we have Bakita Kasadha, who is a writer, researcher and HIV activist holding various roles, including the chair of the Global Network of Young People Living with HIV. I also saw someone put on Twitter today that you're the future Prime Minister. Yeah. Is that? We're getting there, though. And you can tell by the navy blue, we have another doctor. Did you guys share the memo? This is Dr. John Forney. He's a trustee of Make a Difference Trust that fundraises in the theatre industry to support projects for people living with HIV. John has worked in HIV for many years in research and clinical practice, and a huge thanks to Make a Difference Trust for supporting aidsmapLIVE. And finally, he's not wearing navy blue, so I guess you're not a doctor, but you're in stripes. We have Causton-Ronaldson. Alex is a HIV positive campaigner and activist, currently campaign mentor for Youth Stop AIDS. He has previously been a Youth Stop AIDS speaker, as well as a campaigner for THT. Some describe him as passionate, which he knows is a polite way of saying mouthy. Yep. Is that the case? So expect lots from Alex. So thank you to everybody who sent their questions in advance. I have some questions that I'm going to be going over that you've sent with the panel, but please send your questions over, live audience via Facebook and Twitter, and my colleague Roger will be scanning the internet and letting us know about your questions. And we also have a tremendous live audience who have questions at the ready as well. So thank you. So my first question is for Tristan. I've been getting a lot of questions sent over about why people with HIV seem to experience more mental health problems. What's the link between HIV and mental health?
I think in recent years we've got very good at the biomedical management of HIV. We're able to say to people very early on that they can have a very normal life expectancy if they're diagnosed at an early stage of their infection. We're able to monitor them for medical problems and medical conditions. Sometimes, certainly in the UK, we get in there with medicine very, very quickly. And I think in the past maybe we took a little bit longer to get to know people, to understand some of the psychosocial implications of their infection and some of the things that might be important to them before starting with the biomedical side of treatment. And I think some of those things can drop out now a little bit later on in someone's treatment course. Right. And I think it remains the case that HIV can be very frightening to people. It can be stigmatizing. It affects something very personal to them. It can affect their sex life and their ideas about fertility and themselves as being vulnerable. And so there are a number of factors that can affect someone's mental health when they're living with HIV infection, and also how they cope with their HIV infection. And then I think, just to add into that, some of the medicines themselves can have an impact on people's mood and on their cognitive function, even if that's just in the short term, and that can be very frightening and alarming to people. So there are a number of sort of social factors that can impact on your mental health. Sometimes people use alcohol and drugs to cope with their diagnosis, but also the medicines we use themselves can have side effects we need to monitor for.
Right, okay. And what do the rest of you think in relation to that? And I will be coming to you directly about your personal experiences.
But yeah, no, I think that's very right in terms of the alignment between the drugs you take. So when I was first diagnosed, I was put on certain medication, and all of a sudden my mood went through the floor. And it took me a long time to realise the correlation. And eventually, once once I was undetectable, I was able to change the medication, and then all of a sudden it was like a cloud lifted from over my head. And so for a long time, I was going, no, what's wrong with me? What's happening? And I was really confusing and really, I was 24 years old. And it was very alarming for me at the time. And I think, but never did I ever think this is maybe to do with mental health or anything like that, because at 24, it just didn't really seem to come into my sphere of thinking at that moment. So yeah, there's definitely that alignment there with the drugs you take, and also that particular moment in your life, and that sort of small snapshot.
So Alex, what has been the impact of living with HIV on your mental health?
So I think it's interesting, because before I was diagnosed, I was a head in the sand kind of guy, and it was just carry on as normal. And I think since being diagnosed and spending a lot of time with doctors over the last 5 years, I never thought I'd do. I've become a lot more self-aware both of my physical and my mental health. And so since being diagnosed with HIV, I was diagnosed with anxiety and depression, which happened maybe a year or two after my clinical diagnosis with HIV, because my consultant spent 2 years going, please see a psychologist, please see a psychologist, please see a psychologist. And I was like, no, I'm fine. And eventually when I went to see the psychologist, everything started to unravel, and all of the thinking started to unravel, and the depression started to kick in, and things got quite tough for me for a bit. I spiraled into quite a big depression at that moment, and then over the course of the following 6 months to a year and a half, started to build that back up again. It's quite odd, because it was about 2 years after my diagnosis that this all happened, and so it took me a long time to then link it back to that physical diagnosis 2 years prior. And so for a long time, it's like, well, how is that linked? I'm okay with it. I'm okay with it. I've dealt with it, but I hadn't. I just spent 2 years sort of head in the sand and carrying on as normal. And I think so, although obviously there's often that moment of treatment or support at that point of diagnosis and that initial point of care, but actually it was so much longer before I was able to really think about accessing the help I needed. And yeah, so since then, obviously it's been a upward journey.
Fantastic.
So yeah.
So what strategies have helped you cope?
A lot of it was to do with self-esteem and self-worth.
Right.
And it sounds, I say this out loud in front of lots of people, but one of the most simple things that happened was my self-worth went through the floor, and and I really didn't, I had no nothing there really at all. There was no shred of it, and so it was just a case of writing. I had a whiteboard on the back of my bedroom door, and I wrote 5 things on the back of the door of things I was proud of about me every day. And at first I was like, I'm not doing that. I am a full-blown adult. This is ridiculous. But I started to do it. And I'm very glad for the doctors that kept pushing me to do things. Right. And so that really worked for me in terms of just getting my self-esteem back up and my self-worth to a point where I realised that just because I was HIV positive didn't mean that I was no longer a productive member of society. Right. Just because I had to take a couple of extra days off for doctor's appointments and things like that. And because it really did affect my perception of my career. Mm-hmm. So that really helped sort of build that back up, and just spending time around supportive people, and I think I was very lucky in working and volunteering with Terence Higgins Trust and other organisations to meet other HIV positive people, not in a support group environment where we're all sitting there talking about, the last couple of weeks, actually just normalising it and spending time with other HIV positive people and going, hey, you're all people too. This is fun. So yeah, it's little simple things, I think, rather than having strict regimes of different processes that must go through, just to sort of carry on.
Okay, great, thank you. Bakita, do you think that there's more to health for people with HIV than just reducing viral load and boosting CD4 count, which seems to be the real focus of doctors? Not that I'm dissing you guys at all.
The Navy Army.
Yeah, definitely. I think that we, even through the responses that Tristan and Alex have both given, we need to see people living with HIV as beyond viral loads, beyond CD4. So we're more than our immune systems, and we're more than what the HIV is doing within our bodies. And I think focusing on us as whole human beings, recognising us as whole human beings, is important to us managing our HIV status well as well. And I think there is more conversation about the quality of life of people living with HIV, which is really important. There are still discussions about what that means, but the fact that we're having the conversations, I think, is really important. Just that people living with HIV, wherever they are in their HIV journey, are remembering that we are beyond our viral loads, we're beyond our immune systems and our HIV status, and we're whole human beings. And that includes, as we're going to be discussing today, like our mental health as well, the impact that that has on us being able to manage our HIV. And it's important that we're thinking about this holistically.
And is that something that you discuss with your patients at all, doctors?
Yeah, I think, holistic care is clearly the most important thing to the patient. So we are lucky and fortunate in the UK and hopefully globally eventually that we have the right medicines to be able to treat the biological side of it. But living well with HIV and moving towards fourth 90, which is actually looking at how people are living longer term and living well, we're going to have to be much better at actually understanding some of the other issues that are not the numbers and the biology and actually affecting the day-to-day lives of people living with HIV. And so mental health is clearly a big part of that, but there are a number of other things that we also need to take into consideration. And I think it's really about that holistic support we need to provide going forward to make sure that we look at all aspects of people's lives if we're going to really achieve the sort of fourth living well and living holistically. So yeah, totally. I'm sure you're both.
I think for a lot of patients that I see in clinic, HIV is, for a lot of them, is a small part of their life, and they're more worried about all the other things that are affecting them. So, trying to find a job, trying to work out things in terms of family issues and family stresses. There's lots of other things going on, and it's kind of those things that are affecting their mental health and well-being much more than the HIV itself.
I think this is where we have to remember that certainly when finances are tight, people can feel very pressured. If we use the UK setting, I think some clinicians and clinics got a very negative message a few years back that we were only commissioned or asked to provide solely HIV care, and some people, probably not in a very helpful way, translate that overly literally, whereas actually what we need to look at is all the successes we've had in terms of holistic management and how we support clinics with standards nationally or globally to keep offering that holistic care that really helps people live with this long-term condition and do so well, achieving undetectable viral loads, getting better CD4 counts, but also looking at what the holistic care is behind that supports them on that journey.
Yeah.
I think there was definitely for me an interlink between my physical and mental care. For a while, I really struggled to take my medication. And so what I had been undetectable for quite a long time, and all of a sudden the pills just became this sort of this horrible reminder of this person that I was, or this thing that I had, this cross that I bore, whatever I want to call it. But I think for me, for a long time, I suddenly started going, I can't take this medication, and I know a number of people who really struggle with that sort of the physical message that holding those pills in your hand and taking them every day becomes. And I think having both my consultant and a psychologist there to sort of come at it from both angles, I think it was the only way I really managed to get back on track with that, because for a long time, my compliance went quite low, and it became a bit of a problem. This was only sort of 2 years ago, because it can come back. It doesn't, it's not suddenly one day, oh look, I'm living well with HIV now, I'm absolutely fine, I'm going to continue my life. It can creep up on you at times, and I think that was quite surprising for me. So there's definitely has to be that sort of holistic care on both sides, because how knowing you've got a team of people, or the right people at the right time to access, becomes really, really comforting to someone who's struggling with both.
Especially as we know that HIV disproportionately impacts most marginalised within our societies and within the world. So if we're not contextualising how gender, ethnicity, economic status, other things as well that have escaped my mind right now, but you know what I'm saying, in terms of how that also impacts somebody's ability to live well with HIV, to maybe even to get tested, then to get treatment, then to stay on their medication. We have to look at it holistically.
Absolutely. So, Rageshri, would you say that there are some groups that are more affected by issues around mental health and HIV?
I think at the moment, I think we know that people living with HIV may experience more mental health issues or less good well-being. And I think there's a lack of research perhaps looking at some groups. So for example, there's a lack of research looking at the experiences of women, of older people, of people from ethnic minorities and migrants. I think we're still learning about how people's mental health in certain groups. We carried out some work last year as part of the PRIME study, which was looking at older women living with HIV. And in the PRIME study, it had a very large percentage of women from ethnic minorities. And actually, it was very representative of the UK population of people living with HIV. So it was a representative sample, and we found some differences in terms of ethnicity, mental health, and kind of psychosocial issues. So, for example, we found a difference in access to mental health. So we found that our Black African women reported higher levels of psychosocial distress, psychological distress, but were much less likely to be diagnosed with depression or be on antidepressants. So perhaps for them, although this was a study where we didn't ask questions why, it may be related to the fact that perhaps they couldn't talk about their mental health in their consultations with their HIV clinicians, and because of that they weren't accessing mental health services that they needed. Right.
Do you think doctors are doing enough in terms of helping people from communities that historically have been called hard to reach? I mean, I hate that term. I think it's very much that we're just not reaching people effectively.
Well, I talk now about us being hard to reach, so hard to reach clinics, hard to reach doctors.
Yes,
so I think
absolutely.
we definitely need to work harder. I think we need to be more comfortable with knowing how to ask different people about their health and well-being, realising that some people may not recognise that they're having issues with their mental health, they may not recognise their symptoms are due to their mental health, and working out how to work with them. And then acknowledging that, for some people, dealing with poor mental health is a stigma in itself, in addition to living with HIV. So then when you start talking about referring to services, working out ways in which people can find them acceptable to access.
I think it's really acknowledging as well. This is why we have to continue to research into all the areas that Rageshri's mentioned, because there's an assumption sometimes that when we've had a success in HIV, that model fits for everyone. And it really doesn't. And understanding why models work in some communities and some clinic settings and some population groups, but don't work in others, is really key to make sure that we upscale all of that brilliant work for everyone. But we can't rest and think that because we've had success in one group in one place, that applies to everyone everywhere.
Yeah, absolutely. What do you think?
And I think there's also a real importance in terms of the other services that are brought in, so like mental health support services. So my clinician is fantastic, she's really brilliant, and when I raised some of the emotional and mental health distress that I was experiencing, she referred me on to a psychiatrist. But the challenge that I had with that in that conversation was that he immediately in the first discussion recommended antidepressants for me. Now I know that it's a good solution and it can be a very effective solution, but I felt uncomfortable with that being his first thing on offer, especially as at the time I was taking HIV medication that's also linked to depression. And I felt like being referred to by my HIV doctor, I feel like there was more of a responsibility for him to understand the additional things that might be impacting me. So that resulted in me actually only attending one session. And I was like, I also know that Black people are disproportionately more likely to be given medication and offered talking therapies. So that kind of gave me a distrust of the advice that I was receiving from him at the time. So I think, as well as the responsibility of HIV doctors and clinicians, also where we're being referred to non-HIV services, there is also a responsibility on them to make sure that they are providing that holistic care, like I was mentioning before, and contextualising, not just seeing mental health problem in one context without bearing in mind everything else that might be going on in that person's life.
Absolutely. And also in terms of people from trans communities, I mean, John, what are your thoughts in terms of patients that you work with from trans communities? What do you think their mental health needs are, and are they being met effectively?
I mean, I think, as Rageshri said, there's a number of people within the community that are not met, and are not their mental health needs have not been adequately looked at. And I think the trans community are certainly one group within this that have been disproportionately affected and are overrepresented in the mental health arena, but actually are really underrepresented in quite a lot of the work we've done. So again, Rageshri mentioned data and the data to support this. And again, if you look at data around the trans community in this, they are disproportionately affected by mental health issues. I mean, there was a study in Edinburgh, it's 84% looked at suicidal ideation, 49% of those actually went through with some kind of self-harm or looking at committing suicide. And you look at that globally at IS this year, there was some really shocking statistics around the trans community in South America about their life expectancy, about the mental and psychological distresses they go under. And yet I don't think we know enough about the reasons why these are happening and what we can do to ensure as a community that we help support the trans community much better. I think it's a very complex situation in terms of why this has been brought about, but I think that it's a key area that we need to focus much more attention and resource on to really try and understand that. And I'm sure you guys will most definitely have probably had the same sort of experience as well, I don't imagine.
I mean, there are some real issues of intersectionality here, aren't there, where people feel sometimes double stigma in coming out about being transgendered, having mental health issues, being HIV positive, and possibly multiple other issues that may be affecting them. And also, sometimes, much as we really do need good trans representation in terms of upping our game in terms of transgender service delivery and HIV, I think it can be very tiring for people to say, well, I'm fighting one battle and now I've got to fight another, and now I've got to stick my head above the parapet and say I'm HIV positive and also fight for services in that arena. And so supporting people in that role, I think, to make sure that we have good patient representation in some of the research we're doing and some of the service delivery we're planning is really, really important. And again, we have to make ourselves easy to find and not be hard to reach, I think.
And I think it's the reason why services and offers like Clinic Q are so important. So they may not specifically focus on HIV, but sexual health and health generally of trans and non-binary people. It's important because they're recognising two things at the same time or more than that. And I think that's where services are hard to reach, and it's something that Clinic Q is plugging a gap on, in that I see you as you are, as a full human being, and I'm going to provide the services and accordingly.
I think you're absolutely right. I think that's key, and I think you look at where data gaps lie within this population. Clinical trials, for example, totally underrepresented by the trans community. If we look at just service provision, how much of our clinics and our services are really friendly and favourable to the trans community, just things like imagery and gender neutral toilets and using the right pronouns. And there's things like gender identity clinics. The referral rates have gone up hugely in the last few years, and yet you can wait up to 3 years from an appointment. In what other area of clinical practice that we work in would waiting 3 years from an appointment be acceptable? And yet this is what the community has to look to and deal with. So to Tristan's point, there's so many layers that are being dealt with here, and we're not keeping up with trying to help support and go out into and reach out to help support the community. So it's not surprising that they're overrepresented from a mental health perspective.
Absolutely, thank you. And Bakita, you mentioned about being on a medication causing potentially linked to mental health issues. Someone has sent in a question from India. It's a lady who works with people living with HIV, and she says that a number of the people that she works with are experiencing mental health issues from a drug called efavirenz. So can I pass that one? And she would like to know, is this the case, and what can people do about it?
So we certainly know that in a significant proportion of people on efavirenz, they can experience ongoing neuropsychiatric side effects or mental health problems, including worsening of depression. And we know that switching away to other medications is of benefit in that scenario. Some people tolerate efavirenz perfectly well. For them, it's a very good drug, no food restrictions, some flexibility around dosing a little bit because it's got a long half-life. But for some people, it clearly causes problems. And depending on what country they're in, they really do need to look around and see if they're able to switch to another treatment. And there are a number of other treatments that if you switch away from efavirenz, you should see some improvement in your mental health side effects. Of course, no drug is ever perfect, so you have to be briefed on the potential side effects of a switch, but it's perfectly safe to switch for issues of tolerability or side effect management, and you need to find out what else is available in your country setting.
Right. Okay, great. And in terms of, I've also got a question from Kenya, from Kennedy. Hello, Kennedy. How can we best advocate for sustained support for programs that are working on mental health in relation to HIV?
So as you mentioned actually right at the beginning, that I'm the chair of the global network of young people living with HIV. So one of the things we do for people who want to get involved in advocacy generally, on our website there's the Ready to Advocate tool that's kind of a handy guide for young people living with HIV. I think specifically in terms of mental health and support, I would say falls into 3 broad areas really quickly. So evidence, collaborate and linking in. So in terms of evidence, as we've already discussed, we've spoken about those links. There's a lot of research that shows the link between HIV and mental health and how people are disproportionately affected by that. So using that as a means to advocate for whatever it is that you're trying to see and the services that you're trying to embed in your local area. When it comes to collaborating, seeing what other organisations and networks in other areas but are relevant, so mental health support, or even if there are networks that focus on gender-based violence, because we've spoken a lot about intersectionality and how certain groups are disproportionately affected by different things, seeing where you can collaborate with different people as a different way to like use the evidence and the expertise that they have as well. And then the linking in, although I still maintain that we need to look past the numbers, I need to go beyond the viral load and the CD4 counts and all of that sort of stuff. At this present moment in time, the regional measurements and the global measurements are around kind of like viral load and testing and all of that sort of stuff. That's kind of the measurement that is being used at the moment. So using that as a marker to advocate for, if we're improving the mental health of people living with HIV, actually there is an opportunity to have more people tested, have more people on treatment and sustain and adhere to treatment, and using that as like a tool as well.
Okay, great. Thank you. That's very good. I'm going to ask one more question that's been sent in, and then I'll turn it over to the live audience, who I'm sure are chomping at the bit, and to the Facebook Live and the Twitter audience. But is it true that people living with HIV can suffer from a type of post-traumatic stress as a result of HIV diagnosis, and what can be done to combat that?
So I think there is research that shows that can happen. I guess it happens around how the diagnosis occurs and the events around the diagnosis and how traumatic that has been. And I think thinking about how to prevent that would be looking at support services, for example, offering peer support, giving psychological support around the time of diagnosis. Those kind of services can certainly help prevent PTSD.
Gosh, I just want to mention peer support, because I've had so much success with peer support recently. People worry about not having specialist psychologist or psychiatric services to refer into, but I've had patients who've been very resistant to see a psychologist or a psychiatrist who've seen a peer support worker, and it really has changed their whole pathway and their treatment history, because it's just really having someone who's not threatening, who can understand exactly where they are, has just been really, really powerful, and I think that's a really important thing to flag up.
Okay, brilliant.
I think I definitely agree that peer support is essential and it's really important. I think also is the support that the peer supporters get as well, because sometimes they might, especially in areas where there aren't as many mental health services, there is a lot of pressure on them to support people who potentially have undiagnosed mental health conditions, and understanding kind of the different responsibilities or expectations from like a mental health support worker and a peer supporter.
I would also say it's quite good for the peer supporter as well. So I think probably one of the most healing things I ever did was do peer support work, and actually the reward of supporting someone who'd been newly diagnosed was one of the most powerful things I've ever done, I think, in terms of living with HIV. And I think the growth that people go on in a very short space of time, from, as you say, this idea of this terrifying thing, and all of a sudden, actually, this is someone who looks like me, this is someone who talks like me, this is someone who's like me, and they've been living with it fine, and actually going on that healing process together has been really powerful.
Okay, brilliant. So I'm now going to go over to our audience. Does anyone have any questions? Joe.
this is perhaps very obvious, but where do you draw the line between something which is a real, in quotes, mental health issue, which is what Bakita was touching on, and something which is the result of being diagnosed with an unnameable illness and not knowing how it's going to affect you and not knowing what that's going to do to the rest of your life. In the experience of many people I know and myself, it's very easy to say this person is suffering from depression and anxiety, whereas in fact you're reacting quite normally to something which is a life-changing diagnosis and a life-changing experience.
I think there's a very normal, I think you're right to raise that, Jo, thank you. And I think what we see sometimes is essentially a grief reaction, and some people have a normal grief reaction where they are upset and they have to accept their diagnosis, and then they start to build bridges to moving forward. And some people who in that very early period have a very delayed grief reaction and may need some extra support, but as you identify, may not really be suffering from a true underlying depression or anxiety. They've got a reactive stimulus that sometimes is a little bit prolonged, and it's why I come back to that fact that for me at the time of diagnosis, I don't like rushing to label people as stable just because they're undetectable. I think although we've moved to earlier treatment with antiretrovirals, it's tremendously important in that first 12 to 24 months to continue to see people regularly. Of course, you get the odd person who's very clued up on HIV, who's got lots of friends who are HIV positive and doesn't need that intensive follow-up. But for a lot of people, some of the psychological issues will start to drop out, I find, at about 6 to 9 months after diagnosis, perhaps well after the time when they're undetectable. So you need to keep that kind of surveillance and support in place, I think, before labelling people as stable too quickly and moving to 6-monthly appointments and follow-up.
And I think part of the mental health issue is that it doesn't just happen at one point. It's something that can come on throughout your entire life, throughout your entire journey. And so the thing you just talked about, Jo, very much at the start of that, it takes a bit of time to understand what that looks like, but even when you are stable or feel okay, like 2 years down the line, there could be something significant that has an impact on your life that is really quite important, that needs to be dealt with. And I think as healthcare professionals and as people that provide peer support, it's that continuous understanding, that continuous discussion with our patients and our service users that enables us to look at it when it comes on, rather than just say, oh, they've been fine for 12 months, it's all okay and everything's fine and rosy in the garden, when actually a significant life event could have happened, and we need to make sure that we're always thinking about and being on top of that when we are talking to our patients or talking to our service users. So I think it's really key, because depression can be insidious. Of course, it's not something that just comes on and comes off. And so I think that's why it's always very important to just keep that in mind when we are going through the holistic care side and looking at people holistically.
Sure. I go over to Roger. Have you got a question from our virtual audience?
Absolutely. So it's quite interesting. It follows very much on from what we've just been talking about. Clive Blows is asking about long-term survivors and living through the trauma of the early years. And he's saying, particularly in the States, that idea about post-traumatic stress disorder is quite well recognised, and he's asking what can be done to raise awareness of that here in the UK.
Who'd like to take that?
I agree. I think the voice of long-term survivors has been a little bit lost, actually, in the public arena in recent years. We've seen, obviously, some fantastic successes in terms of prevention and earlier treatment of HIV infection. But actually, I think we do need to do a little bit of work to really remind ourselves about how much we've learned and how much we need to continue to support our long-term survivors with HIV. And I have a number who are adjusting to a new expectation, having previously not thought they were going to be alive, having obviously lost friends 20, 30 years ago, having ongoing toxicity from earlier antiretroviral medications and from previous opportunistic infections and AIDS-defining diagnoses. And I think that's why certainly we've started to look at frailty in older people and how to better support people who are aging with HIV. Different clinics are taking different approaches to that. I think there's been a difficulty where people have been asked to see their primary care physician or GP for things that maybe they haven't engaged with their GP for 20 or 30 years, again because their HIV clinic offered to provide everything at a time when treatment was very different. And so the position I take now is very much one of saying to people, I may not be able to provide all of your care, but I should be able to help you coordinate it. And that may include involving your primary care physician. It may include involving other people like psychiatrists and psychology, but please don't feel that you're in a gap where the things are not joining up. And I know that's something that people are starting to advocate for a little bit more, and that clinicians are starting to hear as more of a message that's coming through about how to provide more complex care for ageing patients, but it's not perhaps universally accepted at the moment. And I think it's something we need to keep focusing on. Again, listen to service users, look at the unmet need, and try and think about how we can provide that better in multidisciplinary teams.
Okay, great.
I think the other thing about that is the relationship with your HIV clinician. So in the past, the way services were set up, you saw hopefully the same doctor every time, you were seen more often, and people really developed relationships with their doctors for years and years. And that's changed in more recent years with the kind of advent of stable patient clinics, people maybe not seeing the same person at the same time. And I think that's probably had a big effect for long-term survivors as well, of losing that kind of core relationship with their HIV doctor as well.
I would say though, and I'm glad you mentioned it because it came up in something I think Bakita mentioned earlier, that people often feedback they love seeing the same person because they know their story. There's something quite refreshing sometimes about seeing someone new, although it may feel a little bit uncertain, because I think other people may offer different services, they may ask different questions, they may sometimes have a slightly different approach to a problem that you've been really stuck with. So whilst I think people should have hopefully a named regular person who is again coordinating their care, I think it's quite good if people don't feel too uncomfortable if occasionally they see someone else within a clinic team, because they may find that offers them solutions to problems that they've not been getting past with their regular clinician.
I mean, conversely, in terms of young people, particularly who've been born with HIV and then transition from paediatric to adult care, what's the impact of that sometimes on their mental health?
It's interesting you say that, because as the question about long-term diagnosed came up, I was thinking actually young people living with who were born with HIV are often overlooked as a group of long-term diagnosed people. So in terms of that transition period, I think understanding the uniqueness of, especially within the UK, having a transmission route that is less likely to be spoken about, it comes with its own mental health challenges, because we know the stigma associated with sex, sexually transmitted infections, but then there's a population that has a stigmatized condition, but their route of transmission is very different. For groups of young people living with HIV and transitioning, it's really important that the paediatric care, which eventually ends because they're growing up, has a smooth transition process. And sometimes what we can see, so say for example St Mary's in London, they have a special clinic for young people who are transitioning into teenhood and even young adulthood as well, recognising the additional needs that a young person might have in terms of negotiating their first sexual relationships, understanding what it is to manage their own medication, whereas previous it might have been a guardian, a parent, an uncle or a grandparent. So it's really important, as we've been saying quite consistently throughout, like understanding the different services that different populations need, and that also that globally young people are, so we know that people living with HIV are disproportionately affected by mental ill health, but young people especially so, and then what that means for people who need to be tested, who should get tested, and those who were born with HIV.
Right.
So yeah.
Okay, thank you. Do we have any more questions?
Someone on Twitter has just said that often, well, they said that often people acquire HIV because they're actually in emotional distress, and so it can be a cause as well as a consequence.
Yeah, no, definitely, it's true. It's the reason why I was saying before, like if we're looking at people's quality of life, actually understanding that sometimes you need a certain level of quality of life, mental health and mental well-being, to get tested, and then to also get on treatment and then to sustain treatment as well. So it's we're talking about mental well-being and mental health, it's something that we need to think about before and beyond an HIV status, not just with an HIV status.
Absolutely. I think it's interesting what's changed in the last sort of 5 or 6 years as well. So, you know, back when I moved to London in 2013, it was not a case of if I get HIV, it was when I get HIV. This is sort of pre-prep. It was, you know, my group of gay men in South London. It became an inevitability for us. And so what's happened in the last 5 years and the advent and hopefully eventually the full adoption of PrEP is that actually we were in a position where a lot of my friends just gave up and went, well, I just might as well not use condoms because I'm going to get it eventually anyway. And so that was sort of 2013. Obviously, fast forward to 2019, we're in a very different place. And I think obviously PrEP is so important, has been so critical around the mental well-being of young, obviously looking at men who have sex with men here, young men who have sex with men in London and other areas obviously of high prevalence, where that, you know, having a tool to guard themselves against it will impact, will, you know, increase that mental health to a point where, you know, that self-worth, that self-esteem is there, so they can actually navigate safe sex in different ways. Whereas a 23-year-old coming into London and go, oh God, I don't know how to navigate safe sex, such as myself, who ended up in that position, and it became that inevitability. You know, we're going to hopefully see that shift as well.
I was going to say, I think that's in answer to that, Matthew, a little bit as well. This is where it's very difficult when we look at how healthcare is provided, because most service users would like to see joined up services, whether we're talking about gender identity clinics, whether we're talking about women attending for contraception and for bloodborne virus testing, as well as mental health. And it's about being able to access services where you're asked about your mental health in addition to the primary thing that you might be presenting with, I think is so important. And I think also one of the things I've thought about recently in terms of what you're saying, Alex, is that one of the things HIV has done, for instance, that maybe has been beneficial in terms of long-term health is engaged young men into healthcare, as an example. And so if we take away the HIV, we need to make sure that we're still keeping open access healthcare that maybe isn't just in sexual health services, so that young men and other people who are at risk of HIV infection with the HIV gone continue to have good health outcomes over the long term.
Yeah, absolutely.
Can I just mention a bit about, because Bakita just touched on gender-based violence earlier and talking about things that may increase your risk of getting HIV. We know that certainly people who experience intimate partner violence, for example, may suffer from very low self-esteem. So if your partner is telling you every day that you're worthless, you're not going to think that much of yourself. And certainly it can put people into situations where they're not able to negotiate, for example, condom use, or you know, maybe find out about PrEP and get it. So those kind of gender-based violence as well can, you know, affect people's ways in which they can protect themselves from getting HIV, and certainly their mental health as well.
Absolutely, thank you. Roger, have we got another Facebook question?
Yes. So Marcus King in America was asking if the panel has got any comments to make about drug use, alcohol use, and how that intersects with mental health.
Tristan, I don't know, I'm not picking on you.
And we're back to slightly chicken and egg, aren't we? It's difficult because obviously drugs and alcohol are meant to be fun, and lots of people move to urban areas if they're from groups where they might have not felt they had much fun when they were a teenager, or other may move to urban areas and be exposed to drugs and alcohol that they didn't have in their background in the past. People in urban areas are very often exposed to drugs and alcohol from a young age, may have a different pathway, but there are points where drugs and alcohol become impactful on people's well-being, and that can be magnified, I think, in the context of HIV sometimes. And so we continue to need to have supportive drug and alcohol services for people at risk of and living with HIV to help them maximise the benefits, if you like, but certainly reduce the harms that can be associated with problematic alcohol and drug use. And I will often say to people, I'm not judgmental about what you do, but I'm judgmental about how it makes you feel. And you can certainly see when people are having fun and then that turns the corner into something that's really damaging to them personally, but also to family and friend and working relationships around them.
I think, and it's so important that HIV clinicians have that vernacular and that conversation. And I think for me, when I was diagnosed, and you know, previous to my diagnosis and post, it could have gone very wrong. And I think, and I will be forever grateful for my HIV clinicians who were there and, made sure that didn't happen. And I think, I teached on the edge around my diagnosis, and things could have gone horribly wrong. And it really was my HIV clinicians, my consultants who went above and beyond the call of duty. I mean, absolutely fantastic, to support me to make sure that didn't happen. And to this day, still getting that sort of every so often, that every time I go and see him, it's a conversation of where's your head at, where's your mental health at, and where's the drug and alcohol use at, because it can go off piece quite quickly. And I think HIV clinicians have been so critical in that process.
Fantastic. Have we got
part of it just is looking at holistically, again, looking at holistic care. So looking at drugs and alcohol as a cause of a problem that you sort of fall into, and then trying to find alternatives. So there are huge numbers of social clubs and clubs for pretty much anyone, especially in places like London and Manchester and huge urban areas where you don't necessarily have to fall into the drugs and alcohol thing on a daily basis. You can join a club or a group that you're interested in. Just trying to find alternatives just to that one route that people go down and look at it much more holistically would really help. And I think we just need to be mindful there is a huge amount out there that people can access, and being able to sort of offer that, whether it's a kind of website or a booklet, and just try and provide alternatives to that kind of path they're going down, really lends itself to the holistic care that we should be all looking at.
I think if your route to infection was through drugs and alcohol,
yes,
then I think there's really two paths you go on off that point. One, which is either you go and go on the self-destruction path, or you go, this is, and I used it as a new paragraph in my life essentially, and it was, right, actually I've been diagnosed, what I need to change this, I need to sort this out and really reshape that. And I think it's so important that signposting towards those things that aren't focused around drinking, going out and partying are there and available, because for a lot of people that's exactly what they need at that point.
Fantastic. Roger, is there another Facebook question?
First of all, just a comment from Mark, who actually asked the last question, just to say he's noticing how much of a harm reduction approach you're all espousing, which is not what he tends to find on the other side of the Atlantic. And then actually a new question from Christian Samuel about disclosure, and particularly pressure to disclose on Grindr and other dating apps. Any comments about that?
I'm not going to look at anyone in particular here.
Disclosure on apps specifically. I think the day I put it up on my apps and went, this is me, was probably the most cathartic day of my life, because it got rid of the people that weren't open-minded enough to have that conversation or already were informed enough. And yes, I went on a bit of a crusade for a while of basically informing every single person why they were an absolute idiot, and this is why. But eventually that becomes quite exhausting. It becomes exhausting trying to inform every single person you meet, especially on apps where they can say absolutely horrible things. I personally haven't had too much terrible, horrible things thrown at me, but I know a number of people I've not believed them. They've had to show me the screenshots of some of the awful things that people will say. And so I think from someone who's been through that in terms of navigating the apposphere, I just made that up. That's the thing. It's a case of I suppose from my point of view, the way I've dealt with it, which is actually the people that are too close-minded to engage in a conversation about HIV, who are not informed, who don't want to become informed. I don't want to go near you. We're in a different headspace, and it's quite cathartic to be able to go, actually, I'm good, thanks.
I think there's also something around you mentioned drug and alcohol diversity and not having a monochrome approach to your social life. In a similar way, there was some tweets going around today that were talking about the fact that young gay men in particular now, rather than being raised in a community, if you like, of gay men as they move towards that, are now raised by social networking apps like Grindr. So what they see becomes very factual about how they navigate their sex lives and consent and disclosure. And so I think, again, it's about introducing some diversity. By all means, use apps as a tool, but don't see that as the entirety of how you negotiate disclosure and sexual contacts. Make sure you also go to a bar, make sure you talk to some people, make sure you do something else in your social life. Use them, but have some diversity.
Fantastic. I've got a question from Ant in the back row.
Hello, I've really enjoyed the discussion, so thank you so much. My question is about... I personally myself have been hugely empowered by the U=U message, and it's had a huge impact on my mental health to the better. That's my main little badge here. What impact do you think it's had so far on the mental health of people living with HIV? And do we need to be doing more to get the message out?
Absolutely massive impact. Certainly, try to tell every person we see in clinic about the U=U message for the last, however long that we've been talking about it. And, you can really see, first of all, people's reactions when you talk about it, and then 6 months later, still continue to talk about it in terms of self-esteem, etc. It's made a massive difference. So in terms of the U=U message, yes, it needs to be spread wider to the non-HIV population, to everybody. But I was just thinking, when you were just talking about disclosure and things, I'm thinking about what about those people who aren't undetectable? What is the U=U message doing to those who may not be undetectable, and in terms of their mental health as well?
Could you actually say what U=U? So I've been warned not to use acronyms.
So undetectable equals untransmittable. So if you have a viral load in your blood that is undetectable, you cannot pass HIV on sexually.
Right.
Can I? So I think everybody living with HIV should be able to have the privilege of using the U=U message, so that if I'm undetectable, I'm not transmitting HIV sexually. I think the conversations around that mental health and self-esteem are very delicate, because especially because I work a lot with young people living with HIV, many of whom are not undetectable. So linking to your point, what does it mean for them? That actually primarily we're taking our meds to be well, not to be untransmittable for potential or current sexual partners. I think also, if we're within a UK context where we're doing really well amongst access to treatment and undetectability, but again, that's not what I see reflected amongst young people specifically within this context, but understanding what it means on a global level in different countries where you might not have access to treatment or testing, or you may have access to treatment and you may be undetectable, but you may not know because you don't have access to viral load testing.
Right.
Yeah.
So it's a really important message, and like I said to start with, I hope one day it's something that every person living with HIV is able to use, but actually our accessibility to the message really varies depending on where we are in the world. So not everyone has the empowerment that comes from it, although it can be very empowering.
I think even within the UK context,
Yeah.
I think the last time there was a big mass communications campaign, i.e. TV advert around HIV/AIDS with the 80s, was the gravestone, AIDS equals death. And I think I found this really odd thing when I was diagnosed, was all of a sudden suddenly looking after other people about my diagnosis. And I'm HIV positive. Oh my God! And actually going and spending time explaining it to people. And this has been 5 years I've been doing this for now. And still, every single person I talk to who's not part of the LGBTQ plus community or is not part of, a clinician, etc., is like, oh, that's a surprise. I didn't know that. And so. I think that there's a great out-of-home campaign at the moment that THT have done around Can't Pass It On, which is fantastic to see that on the London Tube. But again, outside of London areas of high prevalence, the outside areas with lots of LGBTQ plus community or people high risk, there is still very little knowledge and access to this U=U message and the Can't Pass It On message. And so it really would be very important if we could get it out there somehow. It would be lovely.
Fantastic. Do we have any more questions from the audience? Yeah, Hussaina.
Thank you, everyone. Actually, touch very important about supporting group, as that is part of my interest work. One of the things which actually I find it very challenging is about we are taking a lot of pressure to support those people who are living with HIV and mental health. The challenge is about referral pathway, because that is just lost in the middle. And then us, who we support those people, we carry a lot of pressure and we don't know how we can try to support this person. So we are holding all the issue of this person, And when you try to engage with the doctors, you can't get through. That is the big challenge. So I don't know how we can work together. Support group organization, we support those people, doctors and consultants.
Doctors.
I think it depends what links you have with the local clinics. So, for example, I can talk about where I work. So we have peer supporters within clinic, and they're part of our multidisciplinary team. So we will discuss patients together, and I think that's maybe an opportunity to get that communication. But I do understand that if perhaps if your group isn't linked to a clinic, then it may be harder, and it may be about trying to establish those pathways with the clinic so there is more two-way discussion. But also, we also touched on earlier about supervision and just how important it is, because you are holding on to a lot of difficult emotional information, and making sure that you have that pathway to access supervision is incredibly important.
I think it's also important. We know that access to psychological services is very diverse, I'm sure in different country settings, but certainly even within London clinics. And I think it's important that if your clinic is not able to provide enough support, that you look at how they're networking with nearby clinics, perhaps within the same geographical area, or where you can find that support, because it really isn't fair that if you attend one clinic you may have excellent services, and if you attend one down the road it's very different. They should be looking at linking up so that for people with complexity, where they may not be able to provide everything in-house, they can at least signpost you to somewhere where you can be supported.
We've only got a couple more minutes. Any quick questions?
Well, I would just like to say that one of the really interesting things is that what seems to have happened is that everything has become very medicalised. And I think there's been this wonderful sort of conversation about the holistic approach. And one of the things that there used to be drop-in centres around London and sort of, beyond. And I think that the loss of those is actually sort of incredibly damaging, because there were places where people could go where they had peer support in terms that they were with people who were dealing with HIV. They could sort of give information, which was not necessarily in a peer support setting as such. And I think that governments really need to sort of look at that somehow this cake needs to be just sliced in a slightly different way, so one gets back to sort of finding centres where people can go who are living with HIV. I mean, I've been living with HIV for sort of 37 years. So I have seen this whole sort of process and seen the way that yes, there have been amazing sort of the way that things have developed medically, but I think there's a huge loss.
Fantastic. Thank you very much for sharing that, Jonathan. Just got 30 seconds. I'd like to end with, what advice would you give to someone who is diagnosed today? Well, not necessarily today, but recently. Yes, for the two of you.
So I think the first thing I would say is that HIV status does not define you, and I would advise them to connect with other people living with HIV who have been doing so for some time and kind of learning from them.
And Alex?
Take a deep breath. It's going to be all right. It sounds really simple to say, but it can just seem such a long way away. So it's going to be okay. Just step up and find the right people that are going to support you. If that's clinicians, if that's other people living with HIV, you're not alone. It's going to be all right.
Okay. Brilliant. Well, thank you so much, panellists. Thank you, live audience. Thank you, Make a Difference Trust. Thank you, Compare the Cloud. This has been wonderful. Thanks again, everyone. Yeah.